Welcome to VT on the Edge. I'm Dr. Ben Winters.
And I'm James Smith.
Today we're going to be talking about potentially one of the most controversial outcomes of a study ever done on vision therapy. And rather than wade through these deep waters ourselves, we were able to go right to the source. I was able to get an interview with Dr. Mitch Scheiman, and we'll be talking today about the CITT-ART. Many of you are probably familiar with the Convergence Insufficiency Symptom Survey. That came from a landmark study that was done by Dr. Mitch Scheiman called the Convergence Insufficiency Treatment Trial. And so to get us started off, let's go ahead and ask James here, what do you know of Dr. Mitch Scheiman?
Well, that's the thing. I don't. I know that I've seen him maybe like at COVD, and I know I've seen his name attached to different things, but I've never really met him personally.
Dr. Scheiman is really well known amongst optometry school students, mostly because of this book right here. It's the textbook on vision therapy, clinical management of binocular vision. And so he and Dr. Mitch Scheiman and Dr. Wick wrote this book. It was the first book that I ever had in vision therapy, second edition. I think they're now on the 5th edition or the 20th edition, one of the two.
Yes.
And but not only that, but we have a lot to thank Dr. Scheiman for. The Convergence Insufficiency Treatment Trial that I was just talking about, that was a randomized treatment trial, a kind of gold standard of research. Placebo-based, multi-centered. It was funded by the National Institute of Health, the National Eye Institute. And so, you know, the people that have always said, yeah, vision therapy is nice, but there's just no good research. Well, now they can't say that, okay?
So was this like one of the largest studies that's ever been done?
Absolutely, yeah. Okay. Millions of dollars to fund this research. And so the study that we're going to talk about today, the CITT-ART, it's the Convergence Insufficiency Treatment Trial, Attention and Reading Trial. That was a study to follow up on this, and very highly anticipated because, okay, we've proven that yes, convergence insufficiency is real. It can be treated with in-office vision therapy. But now we can go and take that one step further. Let's talk about attention and reading and how vision therapy can impact those criteria, which is obviously what we talk a lot about.
Which would be huge to our patients, our parents, to everything that we do.
Absolutely, absolutely. And so before we get too much more into this, because we got a lot of fun things to talk about, let's introduce Dr. Scheiman. He is currently the chief researcher of this treatment trial. He's also the head of research, the lead researcher at Salus University, so that's his full-time position there. Myself, growing up, at least in optometry, hearing his name, I always thought that this was some researcher that found his way to optometry and vision therapy. It was really refreshing for me to hear him talk about where he came from and how he came to this field. Let's go ahead and listen to that clip. So it sounds like you didn't always want to be a researcher.
No, when I look back, it's the strangest thing. I had no intention of doing any of this. All I wanted to do was open my private practice and live happily ever after, a nice little practice and go in and, I was happy I didn't go into medicine. I didn't have emergencies and all that. And it was going to be a great life. And it turned out to be totally different. But none of this was planned. But, I love what I do. Today, I no longer, I've now retired from clinical practice. I sold my VT practice and I don't even teach optometry students anymore. I'm a full-time administrator. Well, 70% of my time I'm administrator. I'm dean of research here at Salus University, and I run a PhD program. And about 30% of my time is still devoted to research.
All right. So after seeing that and not knowing Dr. Scheiman, it sounds like he's the perfect one to run something like this. That he has the expertise and the ability. And so, how did this work out?
So it's really interesting because whenever I'm going to encourage right off the bat here, we're obviously not going to be able to listen to the whole interview. And so we will, in the show notes, have a link to the full interview because there's just so much good stuff there. But yeah, Dr. Scheiman, he's got many years of experience trying to put this whole thing together. So absolutely, if there's anybody to do this, it would be him. And personally, though, it is so nice for me to hear that we've got a friend of optometry. The outcome, this is what we're going to talk about, right? There were some concerns about the outcome of this study. And so at least for me, it's nice to know that we had a friend of optometry, a friend of vision therapy that was conducting the research, and not some indifferent researcher in a white lab coat, right? Having said that, because this is an NIH-funded study, you bet that they had to do all the right things to make sure that it would pass the rigor so that there wasn't bias, even though, yeah, we had an expectation going into this that there wasn't a bias that was going into the research. So Dr. Scheiman, one of the first things I had him do was to kind of go through the methods of how this research was set up.
The study was designed as a randomized clinical trial with masked examiners, and the patients were masked as well. So we recruited 310 children between the ages of 9 and 14. And we chose those ages specifically because we couldn't go younger than 9, because younger than 9, we didn't have a validated symptom survey. We didn't want to go older than 8th grade, because after that, in high school, no matter what you do, you can't change reading very much. So the reading specialist said, if anything, Mitch, you've got to go younger. It would be preferable to go down to 6, between 6 and 7 and 14. But we told her we can't do that. And I regret that. We can't do that because, one of the outcome measures is not possible with that age group. So 9 to 14, 310 patients. Before they started vision therapy, we did about a 2-hour examination, which included vision testing, all the things you think of accommodative binocular vision type testing. And then we did reading testing. We also we excluded all kids with a low IQ. We did the KABC at eligibility to rule out kids who fell below 2 standard deviations below norm in terms of IQ. And we eliminated all kids using the RAT decoding test to rule out kids who had severe language disorders. We didn't want to include that. We assumed that those would be hard to change in VT. And I think most optometrists would agree with that the ones we can change are the ones who do have good decoding skills, and have good vocabulary, but when they try to put it all together, reading for long periods of time, they struggle. So those are the kids we wanted to include. So we ruled those out at the first visit. 100 kids get randomized to placebo therapy, 100 kids get randomized to real VT. The VT that we did is exactly the same as we did in CITT. It was some accommodative work, monocular accommodative work in the beginning. We did a lot of binocular vision work, vectograms, apertural eccentric circles, things like that, a lot of flipper work. So very, very traditional VT. And that was 16 weeks of that. They would come in once a week for that, work with a trained therapist, one-on-one therapy. They would have 15 minutes, 5 times a week of home-based therapy to do. Some of it was computerized so we could monitor them. They were using HTS at home. The placebo group, and we'll probably have to talk about this a little bit more later on, were given procedures that we believed in our heart, we believed that it did not stimulate vergence any more than just reading a book would stimulate vergence. You can't not stimulate vergence to some degree. If you give someone a target to look at 40 centimeters, you're using some accommodative convergence, right? So, but no more than that. And it was not meant to create any accommodative demand more so than, let's say, a reading therapist would create doing reading therapy. And we tried to minimize saccades and pursuits, but if you think about it, it's a challenge to create a placebo that doesn't stimulate saccades, pursuits, accommodation of vergence. We did the best we could. And then we followed the kids every 4 weeks, 4 weeks, 8 weeks, 12 weeks, and 16 weeks. And we monitored their progress. And 16 weeks later, we did an outcome evaluation where we repeated everything we did at the very first evaluation. All the outcome testing was done by masked examiners. So the kids and the parents did not know which group they were in, and the optometrist and the reading therapist did not know which groups they were in either. So everyone was masked. So this is absolutely necessary to create a situation where you have a low likelihood of bias. That's what randomized clinical trials are designed to do. And, you know, to the skeptics who've actually questioned the results of CITT and said, you know, those guys, I don't believe the CITT results because they were biased. They were optometrists. They believed in vision therapy. They wanted the result to show that office-based vision therapy helped. They certainly can no longer say that because we're the same group of folks that we really wanted VT to make a difference. But, you know, we designed a good study. This was a quality study that had very low chance of any bias, high credibility, good quality. We had 100% follow-up for the kids in the placebo group, 96% follow-up in the kids in the office-based vision therapy group. We had, for all the VT sessions, over 4,200 visits for the study. We had a 97% show rate. So everything about the study was quality. In fact, I'm rewriting now the Cochrane collaboration systematic review. We're rewriting it. It's going to go. The new one's going to will be finished this year, sometimes in 2020, I believe, or maybe 2021. And this study, CITT-ART, is the only one that has perfect scores across the board in terms of no chance of bias. So that's the nature of the study.
So Mitch, I've got to jump in here. So how did you do that? How did you get such great compliance during the study?
You know, that it's a credit to our fabulous study coordinators and enthusiastic investigators, the PI at each site, you know, the optometrists and all the investigators at each site. They all, you know, developing relationships with the families, and kind of like, you know, the way you do in private practice with your VT patients. You know how important it is to have your therapists not only be great therapists, but to have great interpersonal skills and you know, to educate you know, why we're doing this. So it's just a credit to the outstanding 120 investigators in the study. No one believed it could be done. In fact, the first time we submitted our grant, the original CITT grant, they said, you can't do this study. People are not going to show up for 12 weeks in a row. And we proved them wrong once, and we proved them wrong twice, and we proved them wrong 3 times. So we know we can do it.
So James, and I'm sure many of you that aren't familiar with the research are just on pins and needles wanting to know, you know, what were the results? The headlines were not great on this research, but I really think, and that's really what I want to focus on, and why one of the reasons I want to do this is there's several very good things that we can focus on that were great results as a result of this research. So let's go ahead and let Dr. Scheiman tell us about that.
This was a great opportunity for us to have a much larger sample size. If you remember the sample size from CITT, there really were just over 200 subjects, and there were 4 groups. So there were about 45, 50 in a group. That's not a big sample size. In this case, we had 200 in the vision therapy group and 100 in placebo group. So we had a much bigger sample size. And basically, we pretty much, with one exception, which we'll talk about, replicated the results. And we showed that vision therapy, office-based vision therapy, was statistically significantly more effective than placebo in improving positive fusion avergence and the near point of convergence. The outcome measure that we used was a combination of the two. So we know that if you're an optometrist and you do VT on a patient, what do you look at after VT? You look at, well, are they no longer CIs? And how do we say they're no longer CIs? They have a normal near point of convergence. They have normal positive fusion avergence. So when you look at the combination, I think the numbers were 78% of the kids in the Office-based Vergence accommodative group met the success criteria for NPC and positive fusion aversions versus about 29% in the placebo group. The problem with the outcome in this study versus CITT, in CITT, the symptoms also improved. There was a significant difference in symptoms between the office-based vision therapy group and the placebo group. In this study, unfortunately, there was not. Both groups improved significantly, more than 10 points, but the placebo group, the difference between the office-based VT group and the placebo group was not statistically significant. So that creates a problem for us, because although we can say that office-based vision therapy improved the clinical measures significantly better than placebo, we can't say the same thing for symptoms, although we certainly can say that symptoms improved. So the bottom line is symptoms improved, positive fusion aversions improved, NPC improved. So when we're writing for instance, in the Cochrane collaboration systematic review, our conclusion is going to be the same, that office-based vision therapy is more effective than placebo for treating CI. So it doesn't really change the total outcome.
Okay, Dr. Winter. So listening to that, it leaves me a little bit confused. Like, is this something that I can talk to my parents and say, this is really good, or is this something I'm not sure? Can you explain it?
Absolutely. So yes, bottom line, and what Dr. Scheiman's saying is that we can even more strongly say than the initial research because of the treatment size that we've got. We can definitely say vision therapy is good at treating convergence insufficiency. It's an effective treatment at treating convergence insufficiency. The problem is last time we could say, and it is more effective than placebo at taking care of the symptoms: double vision, headaches, eye strain, difficulty, concentrating, those types of things. Okay. This time, though, there wasn't a significant difference between the placebo and the treatment group. Both saw improvement. So you can say vision therapy, and we're going to get into this, okay? Vision therapy does improve symptoms, okay? Just doesn't improve it more than placebo. Also, what Dr. Scheiman has talked about, and there's a discussion in the actual research about this, it's called a fragility index. And basically what happened was there were like 4 or 5 in the treatment group that were at a 16, okay? In other words, at the end, if you remember CISS, 16 or more is that you're symptomatic, right? So if they had gotten to 15, no symptoms. There were 5 right on the border. So if 4 of them, I believe, that had just said a half a point lower, then we would have had a successful outcome on that too, that yes, the symptoms were reduced more than placebo.
And if I'm remembering right from that survey, that is very subjective to the person who's making the answer. So if you're having a child answer that question, what's a point to them? It could be very easy for them to say one or the other.
Absolutely, and especially since it's so subjective. Remember, placebo, right? As he'll get into, they were very convinced, or maybe he already said it, they were very convinced that they were actually doing real therapy. And so if it's subjective, you want to tell your researcher that, hey, guess what? Yeah, no, I'm doing good. The symptoms are gone, right? And where we were able to show that better, I think last time, we can't as much this time. But I still think very, very valid to say, even more so to say, vision therapy is effective at treating convergence insufficiency. But now let's get into the elephant in the room. Does vision therapy treat reading? Does it improve reading? And that's where Dr. Scheiman really breaks this down for us.
Okay.
The problem is when we looked at the primary outcome measure, reading, we did not find the primary outcome measure. You have to choose one. The term primary means you choose one outcome measure. So of all the reading tests, we chose the Wyatt 3 reading comprehension test. This is if you're not familiar with that, it's a test administered on a computer screen, and you read a paragraph and then you answer questions. You read another paragraph, you answer questions. And that was the primary outcome measure. And it turns out that both groups improved more than you would expect for the 16-week period of time, right? 4 months. I mean, we do expect every child to show gains in reading, even if you do nothing, right? Just normal education. But I'm saying above and beyond what you would normally expect, both groups improved, but the kids in the placebo groups improved just exactly the same as the kids in the office-based vision therapy group. And that was pretty much across all of the reading measures. So we then said, I can't believe that. Did that really happen? Let's see, what else can we do? Are there some exploratory analyses we can do? So the first thing I thought of, I said, okay, well, let's just look at the VT group itself and let's see how significant those changes were. So instead of looking between groups, you look within group changes. So you'll see in our paper, there's a couple of paragraphs about exploratory analysis within group. And sure enough, we found what I just mentioned, that even though the between group differences were not significant, within group it was it was a nice improvement in reading, more than you would expect. The next thing we looked at, next exploratory analysis, is I said to myself, you know what? Maybe we would see an effect if we separated out the kids in the group of kids that got better. But unfortunately, no, that did not yield any significant difference between the two groups. So we tried, and then the third one, and I'm not even sure this one is in the paper. I'd have to look again. But we said to ourselves as a group, what else could we look at? And we said, well, maybe if we separate out the kids who had reading problems, because Ben, here's an important thing for the listeners to understand. We had readers across the entire spectrum. Some were at the mean, or at the 50th percentile in reading. Some were at the 25th percentile in reading. Some were at the 90th percentile in reading. So I think listeners would argue and say, you know what? The problem is, how can you expect someone who's reading at the 90th percentile to show any improvement after 16 weeks?
Sure.
And I'll tell you, if you ask me later and want to know why we did that, I'll tell you why. But so we said, okay, let's separate out the really good readers, and then let's just look at the people that scored below the 50th percentile, the kids with reading problems. And unfortunately, that did not change the pattern.
So you're saying there were no differences between the placebo and the treatment groups. I know you've thought about this. So what theories do you have? Why was it that way?
Of course, we've been thinking about this. I had about 2 years where I would say about 1 year where I was the only one who knew the results, and my statistician. I couldn't even share it with anyone else, and I agonized this. It affected my sleep for about a year, and then we agonized as a group for a year. And of course, the first thing that comes to mind, and I think the listeners will probably are already thinking this if they haven't thought about it before. They're going to say, well, you had good intentions maybe in terms of the design, but you made a mistake because you didn't compare office-based vision therapy to sham therapy. You compared two different types of office-based vision therapy. You compared office-based vision therapy that stressed vergence and accommodation, and you had another type of office-based vision therapy that stressed maybe more attention, concentration, and maybe to some extent eye movements. And most optometrists would argue that vision therapy involves improving attention and concentration. And since we couldn't control that, after all, we did bring the child in and they would have to look at something, here's just an example of one of the placebo techniques. So since we're talking about that, We all know what a traneglyph looks like. You got the red sheet and the green sheet. You got the red-green glasses. Normally, we put the red-green glasses on and you disparate them, and you're doing fusion divergence work, right? Well, for placebo, we took away the red one and we just used the green one. They would just have the glasses and we pop out one of the lenses. But it looked to them like, what do they know from VT, right? The kid doesn't know, the parent doesn't know. They're putting on these crazy glasses, they're looking at these interesting targets. That must be VT. And in fact, just if anyone's questioning that, 87% of the kids in the real VT group thought they got real VT, and 73% of the kids in the placebo therapy thought they got real VT. So we fooled them. So that was not the issue. If someone questions that, we don't think the kids knew they were in placebo therapy.
I'm really glad that you're going through this, because I think there's a lot of questions about, okay, what did that placebo therapy actually look like?
So let's talk about that training. So this would go on for about 5-6 minutes, where the therapist would say, okay, you see the faces on the traneglyph. I want you to take the pointer and point to the ones that have smiley faces, and then find the ones that are sad and trace it. And now count how many of this and questions like that. So the therapist, just like when you work with a clown vectogram, you have a certain set of questions you ask, point to the fox, or, show me the block, how many blocks have an F on it, those kind of things. So the same kind of questions. So in reality, they had to keep the target clear, right? It had to be in focus, but it's just 40 centimeters, no lenses, and they had to find things. They had to search. So it was a search technique. Another technique would be reading a visual acuity chart placed at 4 meters and just reading it from top to bottom slowly, and then going from the bottom to top, and then doing it with the right eye, and then doing it with the left eye. So that's an example. We had one where let's picture trial frames with 2 Maddox rods, one red and one white. So they're really not going to be fusible. And there's a prism to disparate that. So we don't want it to fuse. We want it to be double. We say, do you see the 2 lines? Okay, now put your fingers on them, and your job is to rotate them until they're perfectly up and down, and then go back. And then we misalign them, and we said the better your eyes are working together, the more quickly you're going to be able to do that. Things like that.
So James, what do you think? Was that a placebo group? Was that sham therapy?
Well, okay. First of all, I am a COVT. I am not a doctor, and I'm not anywhere near what the people involved in this were. And so everything that I say is just off the cuff. But it sounds like a lot what I do with my students, is what I do with my patients. There's so much in that's just ocular motor, and then there's recognition, identification, processing. There's visual guidance, all those different things. There's the discrepancies. All these things are what I'm trying to teach a child in therapy. And so they're going to be learning these things even as they're doing this placebo.
Yeah, it was fun actually listening to James watch the clip, because you're saying, wait a second, that's visual discrimination. Wait, that's like doing a heart chart, right? As they're reading the acuity chart or whatever. Having said that, okay, he during the interview, I can't play this clip, but I don't have time, but he says, I would challenge anyone out there to come up with sham therapy for 16 hours. What are you going to do with the kid? And to that point, I think they had to, especially since, okay, we're talking about convergence insufficiency, totally makes sense to do accommodative convergence therapy and limit it to that to be able to show that correlation between the two. But having said that, a lot of the sham therapy to me is oculomotor therapy, and even someone that is good at oculomotor, I think would really benefit. In fact, some of the really good research done by the King-Devick people are showing really positive correlations between treating oculomotor and seeing improvements in reading. And so if you're treating that, it makes sense that you're going to see improvements in that reading performance. And interestingly, the people that they're seeing the best improvements in the King-Devick research are the kids that are the best readers. So to me, okay, you've got this broad spectrum of kids reading performance. They're all seeing improvements because they're doing visual discrimination. They're working on fixation. They're working on oculomotor. That's just kind of my thought.
I agree.
The other big thing that people are saying is, well, why was there not a no treatment group? And Dr. Scheiman does a really great job of answering that.
One major argument that people could have, skeptics, about our result, they would argue that we made a mistake, and that is the therapy. We compared two types of therapy. And if anything, it would have been, and one of my regrets, and if you ask me later, what would I do if you gave me a do-over, is I would have a third group of no treatment at all. And then I could separate out some of these things. I could separate out the placebo effect if I had a group that didn't get anything at all. But we didn't do that. I mean, one of the reasons we didn't do it is this was about a $10 million study with 310 subjects. If I needed another 150 subjects, another 100 subjects, the price tag goes up and you're not going to get funded. So these are things you have to think about that prevented us from doing what we wanted to do.
James, can you believe that? $10 million in what was 7 years?
It's huge.
It's amazing. I mean, again, hats off to them for the tremendous work that they did. I think it's amazing that they were able to pull it off. I mean, just getting the compliance, getting the funding,
right,
getting this team of experts together. I think that there's just a lot that has to be said to this team, primarily Dr. Scheiman, in getting this study even to make it happen. Another thing that came out that we were talking about is when we talk about the team of researchers, one of the main researchers I asked, were they skeptics? And one of the biggest skeptics was actually the reading expert that they brought in. And it's interesting the reason she had her criticism. She said, Mitch, you're just not going to see an improvement. You don't have enough time. This is 16 weeks and you're not even working on reading. You're doing something that's not reading. You're not going to be able to see that big of an improvement in 16 weeks. And so to me, what's huge is they did see an improvement. Okay. Yes, there wasn't a clinically significant difference between placebo and the treatment group, but there was a huge improvement in both groups in reading over that short period of time. And I would think that the reading expert would be thinking, wait, how did that happen?
Yeah.
How is let's find out what's causing this improvement. And so Dr. Scheiman, I asked him, was this a surprise to her? And this is what he says. That
did surprise her. The magnitude of the improvements were greater than she expected. We talk about effect sizes to try to determine if a result in a clinical trial is clinically meaningful versus just being statistically significant. You sometimes look at the effect. It's called the Cohens D statistic, and some of our effect sizes were 0.7, 0.8, which are considered to be large effects. Yeah, she was surprised by that.
So I did a little bit of research after he talked about the Cohens D.
Good, because that's something I didn't quite understand.
Yeah, he's talking about an effect size, because you have, it's clinically significant, right? We can say,
right,
okay, there's this clinically significant difference. But then that doesn't tell you, well, how significant is it? And so you have something called the effect size, and that's what you get this Cohens D coefficient. And what was really interesting in my research on that is, a 1, okay, would be one standard deviation of difference. So a very, very large difference. And actually, Cohen divided into 3 groups. You have 0.2, which is a small, 0.5 or 0.6, which is a medium, and 0.8, which is a large effect size.
Wow, okay.
And so what did Dr. Scheiman say? A 0.7 or 0.8 is kind of the level of effect sizes they saw in this improvement in reading. Cohen said, it should be a large effect, should be like, to the naked eye that you can see this difference. And to me, that just says so much. I want to make another really big point. Many out there know, James, you definitely know, I've spent the last 5 years really working to get insurance coverage for vision therapy. One of the things that insurance companies point to They automatically point to that joint statement by the Academy, American Academy of Pediatrics and the American Academy of Pediatric Ophthalmology and Strabismus.
Right.
Okay. And what does it say? Vision therapy doesn't treat learning disabilities. Well, if anything, this kind of takes that to the next level, right? Vision therapy doesn't treat reading. Well, we've already talked about that, but just for a second, go with me on this,
right.
Okay? Let's just take that on its face value. Now I can say to insurance companies, yes, I've been telling you that vision therapy doesn't treat learning disabilities. I agree with them. Now we're taking this a step further. Let's take education out of this. I'm a medical provider treating a medical conditions with a proven medical treatment. Let's
Correct.
get the reading out of this, the educational aspect, and let's just talk about the medical condition. And because we're using a proven medical treatment for a medical diagnosis, this should be covered. So I think that this plays as well very strongly to that argument as well. And that's something I brought up with Dr. Scheiman as well.
That's exactly what it shows. And in fact, we now have, because the sample size was larger, we have a much stronger, when you see the Cochrane collaboration systematic review coming out, you'll see we're able to make even stronger statements than before, showing that, this is a medical treatment. And from a medical standpoint and insurance reimbursement standpoint, there's every reason to reimburse this. And really, we're not looking at reading. That's not, it's treating the medical condition.
Pretty interesting stuff.
Yes.
Any other thoughts or questions that you had when you were watching that?
Well, I think it's important as a therapist that, to first of all recognize that there are doctors out there are researchers out there that are trying to find out what we see every day. We see the change in our patients, and we know when that 7-year-old girl comes and hands in that reading assignment that she's just done and the parents are just thrilled. That's what I see. And so to see that they're doing something to find backing for that is just huge. And the second part is to recognize really that we have that opportunity to help that child in a medical sense, okay? And then when we treat that medical condition that you were just talking about, the child then is able to go out there and change, whether it's in education, whether it's in social, whether it's in emotional. And so that I don't have the pressure of trying to teach a child to read. This helps me to realize I'm just trying to treat that condition, and then that child now is equipped to go out and conquer the world that she's going to be living in.
I think that's right. And I think most optometrists are very cautious when it comes to promises that we make about changes in reading. These are secondary effects that happen as we treat the vision condition. I always tell the parents, I'm an optometrist. I'm not an educational specialist. And so when we talk about reading those types of things, those are the people that you need to talk to. But I do know, take away the double vision, take away the headaches, this is going to make it way easier on your child when it comes to academics. The other thing I just want to end with is just again to thank Dr. Scheiman for doing this interview with me. We spent an hour and 15 minutes. It was just a delight to speak with him and to hear all of his insights. And again, I would encourage everyone to go to that full interview to watch the whole thing. I appreciate, just like you were saying, that we have people out there. I hope, and Dr. Scheiman says this as well, that this inspires a whole new generation of practitioners to go out there and to do the research that's needed. Not even necessarily to validate what we're doing, but to find best practices as well. I think that there's a lot that needs to be done. I've done and dabbled a little bit in research, and I'm excited to do more myself. But thank you, Dr. Scheiman, for his lifetime of devotion to this and what he continues. I'm excited about some of the research that he says that he's going to be doing in the future. That really brings us to an end of this VT on the Edge episode. Please get this out there. Please share it with your friends and other therapists. I think this is really something that's an interesting topic. Something, like I said at the start, that came out as being fairly controversial. But as I think that we've talked about, there's a lot of great takeaways from this research. And that's the message that I really hope that we'll be able to get out there. So don't forget, but
make sure that you hit the like button Make sure you subscribe so that you're getting notification that we're having new media and stuff coming out, and go live life on the edge.
I'm sorry, I've got to jump in. So how did you do that? How'd you get such great compliance? This is the weirdest feeling. I'm talking to myself.